I mean, good morning, Keshav. Sorry, it became good afternoon, I guess. Sorry for that. Really, we didn't expect that to happen, but there was some lot of connection troubles going on in this place. Yes. Sorry for the delay, nevertheless. I've been working on it for last 1.5 hours, almost more than that, in fact. But right now, I think 5-10 minutes back only I could establish the connection. Anyways, fine. So this is always good. Thank you, Pushkar. Hi, Hari. Good morning. Good morning, everyone. Sorry, good afternoon, everyone. And we'll be continuing with where we left yesterday. I think we have been completing the seronegative spondyloarthropathies. Let us see some images if possible, because I think we have not yet discussed the seronegative spondyloarthropathies. I think I have a good presentation which I made some time back. Let me try to take that off. Okay. Let us see some images only. And this is basically an example of how probably an inflammatory arthritis really looks like. So in this particular image, what you're seeing is the fact that these guys have swollen joints. So at many places, if you take this area, a lot of areas, like you can see this kind of swollen joint. So most of the time you cannot be really able to tell what's going on here, because you don't know whether it could be rheumatoid arthritis, it could be seronegative spondyloarthropathies. We have no idea. It could be even viral arthritis. Many times we see post-viral arthritis also with a similar kind of a picture. So that's why we just call this as a kind of a undifferentiated arthritis in this setting. So this is a case history, a 30-year-old female with 10 days of polyarticular pain and swelling 1 to 2 hours with morning stiffness. So rheumatoid factor is mildly positive, CCP is negative. So this is one case where most of the practitioners will start treating it as rheumatoid arthritis, but I don't think it's rheumatoid arthritis, because it's just for a period of 10 days, number one. So you have to see that it's only for a period of 10 days. To tell rheumatoid arthritis and to satisfy the criteria for rheumatoid arthritis, the pain should be there for at least like 4 to 6 weeks or more, according to majority of the guidelines. And so many criteria are there. The currently followed one is the ACR EULAR guidelines. That's what we follow. And even though why I don't really teach the criteria, especially in rheumatology or any other places, is the fact because these criteria are not sensitive or not specific in the first place. And they should be used only in research purposes. Only if you're doing some studies, that areas this criteria will be useful. But apart from that, criteria are not going to be that much helpful, to be honest. So I generally don't like using criteria for diagnosis. It's just a common sense, and you just make up your mind, and with the help of clinical background and laboratory investigations, you're just going to take something and analyze it and try treating that. So I generally won't take this 10 days as rheumatoid arthritis. And even though rheumatoid factor is mildly positive, it doesn't mean that this patient is having rheumatoid arthritis. So CCP is negative. So of course, this is definitely, according to me, it's not rheumatoid arthritis, even though they have a morning stiffness with a characteristic rheumatoid distribution of MCP, PIP, and all those stuff. I don't think it's rheumatoid arthritis. So we'll wait for some time. So we want to evaluate for viral arthritis. So that's what happened in this lady. In this lady, it was a parvovirus B19 infection. So that was the kind of arthritis that this lady had. Nevertheless, we leave that. And so this is another example of a periarticular or juxtaarticular osteopenia with joint space narrowing, and we have a marginal erosion as well. Whenever you see this kind of erosions, that indicates a very late stage of arthritis, to be frank. Usually, it's not a feature of early rheumatoid arthritis, even if it's rheumatoid arthritis. So this is what we refer to as a osteopenia. You can see a little blackish kind of an area, a hypodense area, that is osteopenia that's happening over there. And at the same time, you can see the normal joint space here. Probably this could be a normal joint space, but you can see the joint space is much lesser here. So this is definitely a joint space narrowing along with osteopenia, and I can see a little bit of bone that is being taken off, that's and joint marginal erosion that you're seeing. So all these things will tell you that this is a typical inflammatory and erosive arthritis. And classically, we are talking about a rheumatoid arthritis in that regards. Then apart from that, you can see this is an example of a seronegative arthritis. Let me just remove my image so that if it is hiding you, just hold on. Okay, I think now it must be fine. So in this particular example, if you see what has happened is I'm seeing joint space narrowing. So here you can see the joint space that is nice and wide here. Definite joint space narrowing is there. And along with that, I can see a bone that has been eroded here. So this is a clear cut, and along with the periarticular osteopenia, it is a clear cut inflammatory arthritis for sure. And it's an erosive arthritis as well. One of the important erosive arthritis is rheumatoid arthritis. So then we can see this is another example of a sacroiliitis. So this is a Ferguson view, which we are talking about in the yesterday's lecture. So in this, what you're seeing is a early inflammation of the joint space. So, and there is some sort of ankylosis are there, and this sort of ankylosis and narrowing of the joint space is symmetric in this particular example. So because it is symmetric, I'll be thinking more of a ankylosing spondylitis. So this is a joint space narrowing. And this is a late sacroiliitis where I'm not able to see any joint at all in the first place. Joint space is not even there existing. I don't know where is the joint space here. In this, at least I could see the joint space to some extent. Fine. The joint line is still visible, even though it is ankylosed. But in this example, I couldn't even see the joint space. So that's definitely a late form of sacroiliitis here. And this is the example of a spinal involvement where there is a diffuse sort of a calcification with syndesmophyte formation. And this is an example of Achilles tendinitis. We are talking about enthesitis in a big way. So this is an example of an Achilles tendinitis here. And you can also see a sort of calcaneal spur. So that is due to plantar fasciitis. I told you yesterday itself. And this is a sort of episcleritis and scleritis. And along with this patient is also having a uveitis. So this is a typical ocular involvement that happens in the setting of any seronegative spondyloarthropathies. And this is the example of involvement of the DIP joint. So you can see the DIP joint has swollen here. So DIP joint swelling is there. Whenever DIP joint is involved in clinical practice, always think about a psoriatic arthritis. I think this patient shows sort of nail involvement, even though the skin features are not really shown that much in this image, but the nail involvement is very typical. If you see this kind of separation of nail from the nail bed, so what you're seeing here is this is what we refer to as onycholysis. So that's a sort of separation of nail from the nail bed. And if you look closer, there are some areas of nail pitting as well that you're seeing here. So definitely this is a psoriatic arthritis for sure. And this is what you call it as arthritis mutilans, and it's a mutilating form of psoriatic arthritis which can present in certain people. And you can see the digits have been shortened, and you can see the skin has telescoped itself into the proximal area. So this is what we typically refer to as something called opera digit. And this is another example of a psoriatic arthritis. So where you can see the classic deformities that you see in rheumatoid arthritis. So you might be thinking that this patient is actually having a rheumatoid arthritis, but this is not a rheumatoid arthritis because you have a typical example of psoriatic plaques. And this patient had a lot of DIP involvement also. And this is not rheumatoid arthritis. This is due to tenosynovitis caused by any arthritis, which can produce this characteristic ulnar deviation. And at the same time, they are producing that characteristic swan neck deformity. If you see there is a hyperflexion at the DIP joint, here hyperflexion at the many DIP joints are there. So these are swan neck deformities that you are encountering. So what I'm trying to tell is these kind of deformities are not specific for rheumatoid arthritis. Even though classically described for rheumatoid arthritis, they are not going to be specific for rheumatoid arthritis in the first place. They can be in any type of inflammatory arthritis that is going to cause tenosynovitis in the first place. And this is an example of a sausage-shaped digit, what you see. So the digit has lost its normal curvature, and it is looking like a sausage, a completely inflamed digit. So typical of a seronegative spondyloarthropathies, but still these kind of dactylitis are uncommon in ankylosing spondylitis. It can happen to a great extent in the setting of a psoriatic arthritis or probably even a reactive arthritis. This is very common. And this is another example of a psoriatic spondylitis, and psoriasis also can cause a sort of sacroiliitis. And this is another example where you can see, but it's a lot asymmetric. You can see this side is a little different if you see the joint line, and this side if you see it's more narrow. So which means in this example the left side is more affected than the right side. So this kind of asymmetric sacroiliitis usually tells you that it is not ankylosing spondylitis, even though it can happen in the setting of a enteropathic arthritis, but I don't think that will be a very important exam question. Whenever you talk about a symmetric sacroiliitis, you talk about ankylosing spondylitis. This is a case of asymmetric sacroiliitis, which happens in other cases of synovitis spondyloarthropathies. And these are some of the skin changes that you generally get in psoriasis, and the nail changes that you get in psoriasis. This kind of building onycholysis. So this is the separation of the nail that is happening from the nail bed, which can be seen in this image. And you can see a variety of nail changes. All these things tell you, and you can have some psoriatic plaques also here. So these things tell you that this patient is probably having a psoriatic arthritis. And this is a classic penicillin cup deformity. That's also called as a penicillin cup DAP deformity that you encounter in this particular example. So where there is a telescoping that you're seeing here. So this is the penicillin cup DAP deformity that is very classic of a psoriatic arthritis once again. And I think this is an example of a Rhetus syndrome causing conjunctivitis. So, I mean, that's a mnemonic for Rhetus syndrome, isn't it? So can't see, then you have can't P kind of a scenario. So can't P is due to this kind of urethritis, and Rhetus syndrome also produces form of succinate balanitis. So this is an example of urethritis with the urethral discharge, and this is an example of a succinate balanitis that you're encountering. Succinate balanitis is actually painless. This is a painless ulceration. This is not a painful ulceration. Contrast to Rhetus syndrome, contrast to Behçet's syndrome, you have something called a Behçet, isn't it? So where you have a painful aphthous ulceration of the genitalia. So here you don't get any pain in the first place. That's the most important difference. And of course, Behçet will not produce aphthous ulceration in the glans penis, first of all. So Rhetus syndrome can produce this kind of ulcers and this kind of inflammation in the glans penis, but Behçet does not usually produce ulcers in the glans penis. They usually produce in the scrotum, but more often they are going to produce more of a very painful aphthous ulceration. So Rhetus will produce a painless succinate balanitis. That's different. And third is Kahn-Kleinberg. So this is the mnemonic for Rhetus basically. That reactive arthritis, can't see, can't P, and Kahn-Kleinberg. Kahn-Kleinberg because of the sacroiliitis they are going to cause and back pain. And once again, you can see the asymmetricity of the sacroiliitis here. So this area is okay, but this is a lot affected in this zone. So here the right is affected more than the left. So definitely this is an asymmetric sacroiliitis telling you it is unlikely to be ankylosing spondylitis. And you also have a calcaneal spur. So that is because of plantar fasciitis. So can't P, can't see, Kahn-Kleinberg. So that is typical of a reactive arthritis in the first place. And once again, this is another example of a dactylitis, where you're seeing, like this is a best example of this sausage-shaped digit that you're encountering here. So this digit looks like a sausage, and even many other digits are also inflamed in this particular example. This is a typical example of sausage-shaped digit, that's dactylitis. And along with that, this is a case where you have severe keratoderma blennergicum as well. These are hyperkeratotic plaque-like lesions that you generally see in the palms, soles, and probably in the scrotum, and many other areas you can see in the body also. But typical in the palms and soles, we call them as keratoderma blennergicum. And I think this is a characteristic example of an erythema nodosum. So as I told you yesterday, erythema nodosum is basically paniculitis. That's what happens. Very common lesion in IBD patients, especially in those with Crohn's disease. And these are painful, tender lesions that happen in the shin, typically, of the tibia. That's very classical of erythema nodosum. Erythema nodosum is not specific for any particular disease. It can happen in many, many conditions, including tuberculosis, sarcoidosis, certain forms of leprosy, and it can happen in streptococcal infections. So many conditions can produce erythema nodosum. Even Behçet can produce erythema nodosum. So it's not like erythema nodosum is specific for Crohn's disease. It's as a part of skin lesions. It can happen in Crohn's disease and some forms of inflammatory bowel disease. It's painful. It's due to underlying paniculitis. Paniculitis means fat inflammation. That's all. And this is an example of a pyoderma gangrenosum. Most often they'll have a neutrophilic infiltrate. This is very common in the setting of ulcerative colitis than your Crohn's disease. So these are the two skin lesions that we need to know about IBD-related arthritis in this particular example. I think we got some idea of some images that we need to know with regards to the synovitis spondyloarthropathies. I think with this, we can move on to the next type of arthritis. The next type of arthritis is going to be the crystal arthropathy. Crystal arthropathy is what we are going to see in the next upcoming session. So, and apart from that, if there is time, we'll be discussing on the infective arthritis as well. So we'll start with it. So crystal arthropathy, we know there are two. One is the gout, and the second one is the pseudo gout. One is the gout, and second one is the pseudo gout. And there is a beautiful table from NEJM 2012 article. So that's what I'm going to tell now. So the differences between the gout and the pseudo gout, how to differentiate between them. So you have in the acute stage, how can you differentiate? In the chronic stage, how can you differentiate? What are the differences in management, and how you're going to differentiate based on the joint aspiration pole trace microscope. So as far as the acute gout is concerned, it's going to be more sudden onset. It'll be, that's why it's called acute. It's more of a sudden onset. And at the same time, it will be presenting most commonly as a monoarthritis. And we know where the monoarthritis is going to be, and the monoarthritis is going to be classical in the first MTP joint. That's very classical of a gouty arthritis. Remember, this first MTP joint is the first joint to involve in gout in more than 90% of the cases, which means any patient with gout, the first attack usually will be involving the first MTP joint. That's why when you think about a gouty arthritis, even if there is a recurrent arthritis, you have to ask always the history of first MTP joint involvement. Even the past, in the maybe 2 years back, 3 years back, they would have had first MTP involvement. Maybe in the recurrent arthritis, MTP may not be involved, but always there will be a first MTP joint involvement somewhere in the patient's lifetime if they are getting a gouty arthritis. So first MTP. So this involvement of the first MTP joint is what we refer to as something called as a podagra. And we need to know that. And apart from that, if the patient goes for recurrent arthritis, later on, new joints may come up. But usually the first attack will be concerned with the first MTP joint of the great toe only. So the patients may be having associated bursitis, and the patient might be having associated cellulitis also. So many times this gout can be mistaken for cellulitis also. So they might be treating it as cellulitis in certain areas, but it's not. You have to carefully evaluate the joint. That's more important here. And as the patient goes for new attacks, so recurrent attacks, so during that time, additional joints may be involved. Like for example, knee joint, ankle joint, subtalar joints. Additionally, they might get involved, but first attack usually, most often involves the first MTP joint only. So which means the subsequent attacks may be polyarticular. The next attacks, the recurrent attacks may be polyarticular, but usually the first attack generally tends to be monoarticular involving the first MTP joint. That's characteristic feature of an acute gouty arthritis. And as far as pseudo gout is concerned, they can present in a different way. Like for example, they can have a monoarthritis. It's very common, of course. And if they ask monoarthritis, which is the most common joint that is involved, the most common joint involved is the knee joint usually in the monoarthritis. Or alternatively, they can come with this kind of oligoarthritis. So whenever you use the word oligoarthritis, means itself it must be asymmetric. So they can present like that also. If in asymmetric oligoarthritis, again the most common joint and the maximally affected joint will be the knee. Apart from that, they can also involve the wrist. Apart from that, they can also involve the MCP joint. So which means you might be thinking it might be a rheumatoid arthritis as well, but the timing is very important. Rheumatoid arthritis will be for some time, and the serology will be usually positive in the setting of rheumatoid arthritis. Rarely, very, very rarely, gouty arthritis may have axial involvement. But remember, axial involvement is never a possibility in the setting of a gouty arthritis. In pseudo gout, you might have a rare axial involvement. That is what we refer to as something called a Crown-Dehn syndrome. That's referred to as something called a Crown-Dehn syndrome. If they have a rare axial form of an arthritis, fine. And most of the time in gouty arthritis, the attacks will be in the nights. Most often it will be in the nights. So which means the patient will be suffering from intolerable pain in the night. And most often it will be very severe pain, like that kind of somebody threw a burning wax. That's what they tell, hot wax on their feet. So that's how they have that kind of a pain. They'll have arthritis along with that. This kind of a burning sensation will be there, especially those who are suffering from acute gouty arthritis. It's a very painful scenario. It typically does not allow the patient to sleep peacefully in the night. And what will be the chronic features? As far as the chronic features are concerned, the most important feature is the deposition of tophi. That means the soft tissue deposition of that monosodium urate crystal. So that's what we call as tophus. And this tophus deposition can happen in toes, fingers, then it can happen in wrists, then can happen in knees, or they can happen in certain soft tissue areas like bursa. The most important bursa are olecranon bursa and the prepatellar bursa, and it can happen in pinna, and it can happen in Achilles tendon. We know, like majority of the rheumatologic conditions, there are more than 150 bursa are there in the body, but there are two be very commonly affected in majority of the rheumatologic conditions. One is the olecranon bursa, and second is the prepatellar bursa. These are the two bursa that will be involved whenever there is a bursitis in majority of the rheumatologic conditions. Even if there is an isolated bursitis, the olecranon bursa and the prepatellar bursa are the two bursa that are very commonly involved. So bursa can be involved, or the pinna can be affected with this tophi deposition, or it can happen in the Achilles tendon. So it can deposit in the joints also. So tophi deposition is very characteristic in a chronic gout. As far as chronic pseudogout is concerned, there are many different presentations. They can mimic different disorders. Like for example, they can mimic a rheumatoid arthritis called a pseudo-rheumatoid arthritis-like presentation, which typically has a sort of a symmetric polyarthritis kind of a scenario. And they will mimic an inflammatory arthritis, and they'll be inflammatory, which means you can mistake this as a rheumatoid arthritis. And second, we have a pseudo osteoarthritis kind of a pattern, where it can have a kind of a non-inflammatory arthritis. Non-inflammatory arthritis. So that is why I told you, whenever you diagnose a seronegative rheumatoid arthritis, there are so many other diagnoses to consider. Only after you ruled out all those things, then only you can put the diagnosis as seronegative rheumatoid arthritis. But don't put the diagnosis. That's a very bad diagnosis. I don't really think there is anything called seronegative rheumatoid arthritis, which means there will be a lot of things you are missing around. So if you don't have sufficient knowledge, then only you will be putting the diagnosis seronegative RA. But even for that matters, if you are clever enough, you can put a diagnosis of seronegative arthritis, but we don't know whether it's rheumatoid or not. Even that could be a clever form of a diagnosis. But putting a seronegative RA tells you that you are overconfident, and that's not a good way to diagnose, and nobody will accept that. Seronegative RA, rheumatoid arthritis, if the antibodies are negative. Okay, what are the associated conditions with gouty arthritis? There are some associated conditions that can be associated with gouty arthritis. Like for example, the most important will be the obesity and the metabolic syndrome, because obesity is a strong risk factor for developing hyperuricemia, and that is the reason. And many chronic conditions like CKD, because of poor uric acid clearance, there could be hyperuricemia, and congestive cardiac failure. So many conditions can be associated with hyperuricemia. And as far as the pseudogout is concerned, usually we talk about the 3H classically. One is the hyperparathyroidism, number one, and second is the hypomagnesemia, number two, and third is the hereditary hemochromatosis, or any hemochromatosis for that matters. So these are the 3H that are very important in exam that can be associated with pseudogout in the long run, because all these three conditions can produce something called a chondrocalcinosis, which is one of the important findings in the setting of a calcium pyrophosphate deposition disease, that is pseudogout. Then you know what is the crystal that is produced here. The most important crystal is the monosodium urate crystal. Here the most important crystal is the calcium pyrophosphate crystal. That is the reason why it is called as CPPD, calcium pyrophosphate deposition disease. Then if they ask you investigation of choice for both these disorders, you are going to go for an arthrocentesis, sinus fluid analysis. So I can write in any way, either arthrocentesis, or I can write as joint aspiration, or I can write as sinus fluid analysis also. That's going to be the investigation of choice and gold standard, especially in acute cases. That will be the best investigation, where you will typically see an inflammatory fluid. That's what you see. You're going to see inflammatory fluid. But there are variants. Suppose if you take a chronic pseudogout, sometimes they can show a non-inflammatory fluid also, because they can mimic osteoarthritis also. You have to be a little careful in that. So that is why inflammatory fluid is most common, but you can get some different picture also depending on the patient-to-patient variation. So you should not take a chance. You send the patient send the fluid for polarized microscopy if you have a suspicion. In polarized microscopy, you will be seeing the typical crystals, that is the needle-shaped crystals, that are negatively birefringent. So that will clinch you the diagnosis. Needle-shaped crystals that are negatively birefringent polarized microscope is going to tell you that it's a gouty arthritis. But to tell it's an acute gouty arthritis, one characteristic finding is there that you will have a neutrophil. Let us assume there's a neutrophil, and inside the neutrophil you will be seeing these crystals, monosodium urate crystals. So whenever you see this monosodium urate crystals inside the neutrophil, that literally confirms that it's a acute gout. So because neutrophils doesn't have any business to come there in chronic conditions or in a stable condition. During acute gout, they inflame. I mean, they come into the joint, they get deposited there, and they tend to swallow the joint, and they release the inflammatory mediators so that they will start the joint inflammation around them. And as far as the pseudogout is concerned, we know once you send this fluid to the polarized microscopy, you are going to result in something like this. That is, you're going to see this kind of rhomboid shaped crystals that will be weakly positive birefringence, with weakly positive birefringence. That is characteristic of a pseudogout. And similarly, same thing. In acute pseudogout, you will be seeing that crystals within the neutrophils. If you see that, that's very, very specific for acute pseudogout rather than a chronic pseudogout. Fine. So these are typical findings. And apart from that, there are some X-ray findings also. Remember, in acute gout, I don't think X-ray will be showing any finding. Usually you will get non-specific findings like surrounding soft tissue swelling will be there. That's all. And remember, gout is one condition which may not produce any joint space narrowing at all. So you might have a preserved joint space. So that's very characteristic of an acute gout. So don't expect the joint space narrowing to happen. But whereas in the chronic gout or a chronic gouty arthritis, you can see this tophi. So that's the idea. And at the same time, you'll be seeing one group of signs called Martel sign. So with this, you can explain everything in Martel sign. And best area to see is the first MTP joint, which is very commonly involved. Suppose if I take the first MTP joint like this, so if this is a distal phalanx, and if you take this is the middle phalanx or proximal phalanx. So let me first rub this sides, because the sides will be eroded a little bit, and you will be seeing this kind of margins on the side. So this is kind of a punched out lesion. I mean, more than for ulcers you call punched out, but here in joints we call them as something called overhanging edges. You'll see overhanging edges, and there will be a surrounding soft tissue inflammation. So this soft tissue that is, increased density that is seen surrounding the joint is basically nothing but the tophus. That is the monosodium urate crystal deposition, and you will be seeing an erosion with overhanging edges. Side you will have an erosion with overhanging edges. This is characteristic of like chronic gout, and this is what we refer to as something called a Martel sign, which I'll tell you in some time. What does that mean? Typically, similarly, you can find this kind of appearance in ultrasound also. There is a whole separate textbook for musculoskeletal ultrasound. That's a very important upcoming field in radiology. In musculoskeletal ultrasound, you will be seeing something called a double contour appearance or a double contour sign. So that's a very important sign in the setting of a chronic gout for that matters. And at the same time, the most important finding as far as the pseudogout is concerned, maybe in acute or maybe in chronic, is the chondrocalcinosis. Chondrocalcinosis means calcification of the articular cartilage. So chondrocalcinosis, and there are many different types of chondrocalcinosis. It can be speckle type of calcification, linear type of calcification. So, but linear type of calcifications are more specific for development of pseudogout compared to that of speckled type of calcification. You can see within the cartilage, you can see within the menisci of the knee joint. So you can see that. So that's a very, very important finding in chronic or acute pseudogout. But remember, chondrocalcinosis is not specific for pseudogout, which means it's not specific for CPPD. In the sense, presence of chronic chondrocalcinosis does not mean the patient will have definitely CPPD. But on the other hand, the reverse is true. Presence of CPPD means most of the patients will have an underlying chondrocalcinosis. But presence of chondrocalcinosis does not really mean the patient should have a CPPD. So it's a kind of that kind of a finding. So which you should keep in mind. And as far as treatment is concerned, treatment is same for both, because we don't really have that much trials that tell the like treatment of pseudo gout. But for acute gouty arthritis, there has been some treatment that have been suggested. For example, in acute gouty arthritis, NSAIDs are supposed to be the first line. But the problem with NSAIDs is they have risk of GI bleeding. In ulcer patients you can't give, and in renal failure patients you can't give. So you have other options like colchicine. You have other options like glucocorticoids. You have even other options like IL-1 beta inhibitors like canakinumab. Canakinumab is a IL-1 beta inhibitor. It's like an IL-1 inhibitor like anakinra only, but it is approved for use in acute gout. Because in acute gout, the most important cytokine that's been thought to produce this acute gout is coming from the inflammatory cells is IL-1 beta. IL-1 beta is thought to be one of the important cytokine that mediates this acute inflammation in acute gout. So that's why acute gout, this canakinumab is also approved. But in general, most of the times, this NSAIDs with or without a little bit of glucocorticoids must be doing the job. But colchicine, one word about colchicine is the fact that this is the only drug that can be used for acute gout as well as for maintenance of chronic gouty arthritis. This is the only drug that can be used for both acute scenario as well as chronic maintenance therapy. Apart from that, none of the other drugs can be used for chronic maintenance therapy. Only colchicine can be used as a bridge between acute gout as well as chronic maintenance therapy. But you know the side effects of colchicine. We need not tell much about it. Everyone who's studying a good pharmacology must be aware of the side effects of colchicine. So what is the side effect of colchicine? The most common side effect, the most important side effect of colchicine. Colicky pain, but more importantly, it is diarrhea. Diarrhea is the most important side effect of colchicine. And colchicine is a drug that we know for ages together. For example, we know for centuries, where a lot of plants do contain this, plant roots contain this colchicine, and it's been used traditionally to treat this joint pains and all in a traditional Ayurvedic practice also. But during that time itself, in the olden centuries before, there is a saying, whenever you use colchicine, there's a saying called you run before you walk. So there's a lot of meaning in that, isn't it? Because they get diarrhea. That's why they gave that particular term, you run before you walk, if you take colchicine. So because you run for diarrhea before you start walking out of arthritis. All right, so that's a very important side effect to know. Then apart from that diarrheal side effect, other side effects, and one of the dangerous side effects is bone marrow suppression, which can result in agranulocytosis. Because colchicine works on basically on the microtubules, especially on the neutrophils. If the microtubules are not performing properly, they cannot move to the site of inflammation. That's why colchicine works. But on the other hand, they can produce severe bone marrow suppression, and they can result in agranulocytosis for that matter, which has to be taken into consideration. And this is considered to be a very dangerous side effect, agranulocytosis. This can happen in a very small proportion of patients who are taking colchicine. And you can develop myopathy, you can develop neuropathy. So especially if you take colchicine for a longer run, all these things can happen. But nevertheless, it's the only drug that is approved for use in both acute as well as maintenance therapy. And there has been a variety of questions with regards to usage of allopurinol. We talk about uric acid lowering agents in acute gout. Whether you can use uric acid lowering agents like allopurinol or febuxostat. Answer is no right now. There's no indication to start with allopurinol or other uric acid lowering agents like febuxostat. So in the sense, guidelines are very clear. In a fresh new acute attack where the patient is not taking any uric acid lowering agents, then in that setting you need not start with uric acid lowering agents, but you can continue them in the sense like if the patient is already taking a uric acid lowering agent chronically, for example, they have been taking allopurinol, febuxostat for years together, or maybe for 8 months, 9 months, they've been taking for a long time for uric acid lowering purpose. If that patient develops a new attack of acute gout, then you can continue them even during the acute attack. The patient is already taking, then continue them during the acute attack also. No need to stop unnecessarily. If the patient is not taking already, no need to start uric acid lowering therapy during the acute attack. And the reason is that because it's been a widespread thinking in the past that starting a uric acid lowering therapy due to unknown reasons has increased risk of developing acute flares, and it might worsen the acute attack of gout. So that's why they don't want to start allopurinol during the time of acute attack. But even though that is highly questioned nowadays, because there are some 3-4 trials which are already going, that is to test whether this statement is true or not, whether starting allopurinol during an acute attack of gout has any adverse outcomes or flaring up of the acute attack or something. So, but the trials are ongoing, and it is promising also. It's telling that it is not associated like that. It's a traditional belief that allopurinol worsens the acute attack, but there is nothing like that. That's what the trial results are so far mentioning us, but it is not published yet, so we cannot tell that. But let us move on to the traditional textbook saying that allopurinol need not be started in an acute attack if the patient is not already taking allopurinol. But on the other hand, if the patient is already taking allopurinol, then you can just continue them during the acute attack also, not a problem. And at the same time, serum uric acid is one of the useless investigations in acute attack. So serum uric acid in acute attack is not very useful because in 25 to 40% of the cases, it can be completely normal. So that is thought to be due to the uric acid sequestration into the joint. So because the uric acid gets sequestered into the joint, the serum uric acid may be falsely normal. So serum uric acid being normal does not tell you that the patient is not suffering from an acute attack. So that's the final take home. If it's elevated, all right. But if it's normal, then it does not rule out an acute attack of gout in the first place. Clear. As far as NSAIDs is concerned, you know, they're going to be a little bad in the setting of a GA bleeding. They have side effect of GA bleeding. In peptic ulcer disease, you have to be careful. In renal failure, you have to be careful. These are 3 situations where we generally tend to avoid giving NSAIDs for that matters. And there is no specific NSAID like that can be effective or not effective, but in general, in our practice, we prefer aceclofenac, ibuprofen, indomethacin. All these NSAIDs are equally effective. These are 3 very commonly used NSAIDs in clinical practice. As glucocorticoids is concerned, before starting with any form of glucocorticoid, the most important thing is rule out joint infection. I told you, because gout presents with monoarthritis, it's always mandated to rule out joint infection, mandated to rule out septic arthritis. So always do a sinus fluid aspirate and prove that the patient is not really having a sepsis, and then you start with glucocorticoids. Because if you start with glucocorticoids, if the patient is having a septic arthritis, then it's going to be a catastrophe in that scenario. So that's why this has to be a little careful. So you have to always rule out joint infection before starting glucocorticoids. And as far as canakinumab is concerned, canakinumab is actually very good, to be honest, but they're highly costly. They're extremely costly, like 80,000-90,000, even in the best case scenarios. So, but still, if patient is willing to spend that much, then you can start with canakinumab, not a problem. But there is no study that tells you which is the best therapy. So even though some guidelines give you first, second, third, fourth, like that kind of an option, but that is just based on the cost and experience. But there is no study that tells you that this is more efficacious and that is more efficacious. So we're not categorizing based on efficacy purpose. We're actually giving based on the cost and the experience-based purpose. So that is why we are giving this kind of protocol and strategies to treat acute gouty arthritis. But as far as the pseudogout is concerned, we don't really know how to treat an acute pseudogout because we don't have any trials or data to tell for sure that this is going to be the treatment of pseudogout. But nevertheless, the treatment is just extrapolated from acute gouty arthritis, which means the same thing we are going to use in pseudogout also. NSAIDs work very well in pseudogout. Steroids work very well in acute pseudogout. But colchicine, like it's kind of a plus or minus kind of a scenario, which means it's not that effective like that in gout scenarios, but it can be somewhat effective, but not very much preferred in the setting of a pseudogout. But more importantly, this NSAIDs and steroids are going to be the mainstay in the setting of a acute pseudogout. That's what we're going to use. But chronic gout and chronic pseudogout, how you're going to treat is completely different. So for understanding the treatment for chronic gouty arthritis, you need to really know what are the cause of hyperuricemia in the first place, and what are the indications to treat a chronic gout. So first of all, whenever the patient is having hyperuricemia, we need to know the definition of hyperuricemia. So whenever the serum uric acid is more than 6.7 milligrams per deciliter, so this is the time where we call it as a hyperuricemia. So why we keep a cutoff of 6.7? Because at this point, the uric acid will not be stable, in the sense like it will not be in the dissolved form. It starts getting crystallized as monosodium urate crystals. So that is why this is set as a cutoff for a hyperuricemia. Nevertheless, hyperuricemia patients can be divided into two. So it can be due to two forms. Either it could be under excretion, which is the actually most commonest form. 85% of them will be under excretors only. And second form, we call them as overproducers. And 15% of the hyperuricemia patients will be basically overproducers. As far as the under excretors are concerned, the most important reason will be some medications which we'll be talking about in some time. Apart from that, it might be due to, many of the cases will be idiopathic, which means we don't know the cause why they are under excreting uric acid. There might be some problems in the urate transporters which are taking up more uric acid or reabsorbing more uric acid in the urine. So that could be the reason. But we really clearly don't know what is the real reason for getting hyperuricemia in a lot of patients. And of course, reduced renal function, which means CKD, AKA patients will have hyperuricemia. And of course, obesity and metabolic syndrome is a very important cause of increased uric acid turnover. Increased cell turnover. Because of that, you can have increased uric acid, and obesity and metabolic syndrome will also result in reduced excretion of uric acid in the urine due to some unknown reasons. So these are the usual reasons why you get hyperuricemia, the most common being under excretion. And as far as the overproducers are concerned, the diet is a very important reason for overproducing uric acid. The most important food that overproduces uric acid in the body is the red meat. Of course, we know red meat is very important, like beef, pork, if you're taking in excess amount. So that's a red meat. And mutton, especially the lamb and mutton, if you take in excess amounts, that is also one of the reasons for developing hyperuricemia. And seafood, to an extent, if you take in too much excess, they can also result in hyperuricemia. And if you're going to take a lot of beer, in general, any alcoholic beverages can result in development of hyperuricemia, but long-standing and large volume of beer intake can result in development of hyperuricemia, because these contain certain compounds that when they are metabolized, they produce more uric acid in the body. And whenever there is a high cell turnover, in the body, you can get hyperuricemia. For example, in the setting of psoriasis, for example, you have a high cell turnover in the form of that skin peeling will happen, the plaques will go off and there will be new plaques that will be formed. So that's one example. Tumor lysis syndrome may be another example, or any tumor for that matters. Not only the tumor lysis that happens, or any tumor for that matters, can produce a hyperuricemia because of high cell turnover. But in general, this is most common with the hematologic cancer compared to a solid organ tumor. So this is one important thing. And then apart from that, you can get in certain genetic conditions. So like Lesch-Nyhan syndrome, that's not very important because that's a very rare disorder. Lesch-Nyhan syndrome, you know what is Lesch-Nyhan syndrome? It is due to HGPRT deficiency, hypoxanthine guanine phosphoribosyltransferase transferase, HGPRT deficiency, where patient will be having a little bit of mental retardation and they will be having that kind of a self-mutilating behavior. So recurrent, a patient who's having hyperuricemia and related problems, having mental retardation and self-mutilation. So usually in exam that diagnosis goes towards a Lesch-Nyhan syndrome, but that's very rare. They don't really ask in exam, but still you can know some few points about Lesch-Nyhan syndrome also, which is a cause of overproduction of uric acid in the body. So we can categorize into two. So the most common, of course, is going to be the under excretors rather than overproduce. And remember, even fructose containing foods, if you're taking more of a fructose containing foods, because fructose generally tends to produce more ATP. More ATP means more purines. More purines means more uric acid. So that's why high fructose containing foods, if taken in a considerably large amount, it can result in hyperuricemia and subsequent gout. But whatever may be the cause, whenever the patient is having hyperuricemia, that is if the serum uric acid is more than or equal to 6.7 milligrams per deciliter, which is what we refer to as hyperuricemia, we have to categorize into two things, whether the patient is having asymptomatic hyperuricemia or a symptomatic hyperuricemia. So if the patient is having asymptomatic hyperuricemia, no need to treat at all. So you can just observe and you can give lifestyle modifications. The patient is having asymptomatic hyperuricemia. On the other hand, if the patient is having some symptomatic hyperuricemia, in that itself, we have some indications to treat. So what are the indications to treat in the setting of a symptomatic hyperuricemia? For example, if the patient is having at least 2 attacks of acute gout in a year, in 12 months, the last 12 months in a year, if the patient has at least 2 attacks of acute gout, and second, if the patient is having nephrolithiasis, that is uric acid stones, And number 3, if the patient is having CKD, that is any patient with EGFR less than 90 mL per minute per 1.73 meter square. So those patients can be started with uric acid lowering agents. Apart from that, the patient is having tophi deposition, which means you are clearly seeing soft tissue deposition, the joint deposition of uric acid crystals in a long run. So this is an example of a chronic gout. So the patient is having a tophi. So in this setting, definitely I can start with the uric acid lowering therapy. So these are the usual reasons for starting uric acid lowering therapy. So once you know there are some indications to treat, now we are trying to see whether the patient is overproducing or whether the patient is under-excreting. Whatever may be the case, you're going to straight away start with the first line drug, that is allopurinol. So I'll tell you why you have to know whether it is a overproducing or under-excreter, and what is the definition of a overproducer versus under-excreter. For that, before starting the treatment, you need to do something called a 24-hour urinary uric acid. 24-hour urinary uric acid is very important. Suppose in the 24-hour urinary uric acid that you do, if the amount of uric acid that is generated is more than 600 milligram per day, I mean, it's more than 800 milligram per day, that will be called as overproduction. If the patient in the presence of hyperuricemia, if they are excreting less, that is less than 800 milligram per day, this will be termed as under-excretion. So you need to know the definition clearly, then only you start the treatment. We start with allopurinol. This is the first line treatment. I'll tell you what are the side effects of allopurinol in some time, but nevertheless, it's a very important drug. Suppose if allopurinol cannot be used, for example, allopurinol is contraindicated or allopurinol is not tolerated, in this setting, you can start with febuxostat. Only in the setting if allopurinol cannot be used. But remember, both are xanthine oxidase inhibitors. Both allopurinol as well as febuxostat are xanthine oxidase inhibitors. In the sense, allopurinol is a purine-based xanthine oxidase inhibitor, which means it is a competitive inhibitor. It's like a purine only. Whereas febuxostat, on the other hand, is a non-purine xanthine oxidase inhibitor, which means it's not a competitive inhibitor. It's a non-competitive inhibitor. But remember, you should never add allopurinol and febuxostat together. It's either or. Most of the times, like methotrexate, leflunomide. We don't add, I mean, we do add methotrexate, leflunomide sometimes in certain scenarios, but generally to start with, I told you yesterday, we don't add methotrexate, leflunomide together. Similarly, allopurinol and febuxostat should never be added together, either or. So either you give allopurinol or you give febuxostat. Don't give both these drugs together. They have no additive benefit and the side effects may be more higher. Both are basically xanthine oxidase inhibitors only. So the dosage, as for the dosage is concerned, the maximum dose that you can usually start with maybe around 50 to 100 milligram per day, depending on 50 to 100 milligram per day, depending on the kidney function. If the kidney function, for example, if the EGFR is less than 40 to 50, then we start with 50. Suppose if the EGFR is more than 40 to 50, then we can start with 100 milligram per day. This is a starting dose. And the maximum dose that you're going to reach is approximately around 800 milligram per day. This is the maximum dose that you can reach. Usual starting dose of febuxostat is approximately around 40 milligram per day. And the maximum dose that you can reach is approximately 120 milligrams per day. So this is the maximum dose that you can reach. Remember, both these drugs are very safe in renal failure, even though small dose adjustments has to be given. But both xanthine oxidase inhibitors are basically safe in renal failure. You can start even in renal failure. There will be no problem. But a small dose adjustment is required in the setting of allopurinol, especially in patients who are having severe renal failure. But nevertheless, both are extremely safe. They're not proven to be any nephrotoxic. That's the take-home point. But the problem with allopurinol is its side effects. That's the more important thing. So one of the important side effect is called as AHS, that is allopurinol hypersensitivity syndrome. Very important question in exam, because this has a very high mortality. So if it happens, it has almost 10 to 25% mortality, but it doesn't, fortunately, it's not a very common entity. But still, you need to consider this fact very strongly, allopurinol hypersensitivity syndrome. So even if the first instant of getting a rash with allopurinol, so you should always think about this kind of allopurinol hypersensitivity syndrome, even though all the rashes are not AHS. Some rashes will disappear spontaneously, but on the safer side, whenever the patient gets a rash after allopurinol, better to stop. But it's been clearly proven not all the rash will become AHS, allopurinol hypersensitivity syndrome, but rashes can happen separately without AHS also. But don't take chance in clinical practice. Stop immediately the ones you know that the patient is getting rashes. And I'll talk about that in some time. You can see bone marrow suppression, and bone marrow suppression can be a feature of febuxostat also. But bone marrow suppression incidence is very high if you are giving with other purine analogs. Can you tell what are the other purine analogs which you commonly use in clinical practice? What are the other purine analogs which you commonly use? We have discussed already yesterday. One purine analog that is used as a treatment for rheumatoid arthritis, but sparingly used in rheumatoid arthritis is not so helpful. What is that? Yes, azathioprine and 6-mercaptopurine. We discussed already yesterday. Azathioprine and we have 6-mercaptopurine. Both are purine analogs only. Suppose if you are using side by side an azathioprine for different reason, if you are using an azathioprine or 6-mercaptopurine, in that setting the risk is very, very high. So they can cause severe bone marrow suppression also, which you should be very careful about. And at the same time, they can produce hepatitis and nephrotoxicity. So you have to monitor with not only CBC, with LFT also you have to monitor. And that's it. So, but as far as the allopurinol hypersensitivity is concerned, we need to know about certain HLA association with allopurinol hypersensitivity syndrome. In exam, there will be 3 things they will be asking about allopurinol hypersensitivity. HLA. One is what is the HLA molecule that is associated with allopurinol, and second is what is the HLA molecule that is basically associated with abacavir, and third is what is the HLA molecule that is basically associated with your carbamazepine. These are 3 things. So I'm going to write side by side. So HLA association with 3 drugs. So first one is abacavir, the most important of all, because it's one of the very, very important drugs as far as our clinical practice in HIV is concerned. Then we have allopurinol, and we have carbamazepine. These are 3 drugs that are very important. So what is the HLA association as far as abacavir is concerned? You have HLA B5701. This is commercially available to test. Very, very important. Without testing, we don't give abacavir nowadays, because abacavir can also result in fatal hypersensitivity if the patient is HLA B5701 positive. Suppose if the patient is having HLA B5801 positive, then that indicates a high risk of developing allopurinol hypersensitivity. So always, in the tertiary care setting, before starting allopurinol, do a HLA 5801. If you do a B5801 and if it is negative, it's unlikely to develop allopurinol hypersensitivity. If there is a 5801 positivity, we generally avoid allopurinol, because there is 70 to 80% chance that the patient will go for allopurinol hypersensitivity syndrome. And as far as carbamazepine is concerned, it's associated with something called HLA B1503. That's a very important number again. So these are the 3 things that are commercially available right now in many tertiary care centers. But of course, the most important of all will be the abacavir. Abacavir is going to be the most important of all. And that's really, really important to know in the first place. Fine. All right. So that's what I want to tell about allopurinol hypersensitivity. As far as the febuxostat is concerned, they also can produce a rash, but they don't have that risk of hypersensitivity syndrome and death. And at the same time, they can also produce bone marrow suppression. And because it's a xanthine oxidase inhibitor, they also have a slightly high risk of bone marrow suppression with azathioprine and 6-mercaptopurine. And at the same time, they can also produce hepatitis, and you have to monitor them with LFTs and CBCs, of course. Apart from that, they can produce GIT side effects more than that of allopurinol, like nausea, vomiting, and all this stuff. So GI side effects are also there, but they are not very, very significant enough to stop the drug anyways. Suppose if the patient is not responding to your protein, not responding in the sense your uric acid is not getting under control. So suppose if uric acid, whether it is less than 6 milligrams per deciliter or not, this is the target uric acid that we need to know as far as hyperuricemia is concerned. So you have to ask whether targets are reached or not. If the targets are okay, reached, then in this setting you continue the same medications, no need to change anything. The targets are not reached yet, which means the uric acid is still more than 6. So in this setting, you see whether it's overproducer or under-excreter, overproducer or under-excreter. That's why we know this data in the beginning itself. If the patient is an under-excreter, in that scenario, you can use uricosuric agents. Uricosurics are there, or you can use some alternative drugs also. Alternative drugs as well. So, but remember, uricosuric shouldn't be used only in patients who are under excretors because they inhibit the uric acid reabsorbing transporters. So, that's called urate transporters. So, they reabsorb the uric acid in the kidney. So, they inhibit those transporters so that you can increase uric acid excretion from the body more. But the problem, because they are uricosuric agents, they produce more uric acid excretion in the kidney. They have increased chance of getting nephrolithiasis. Even though they can reduce the serum uric acid, but they can increase the stones in the kidney and the urinary tract. Because they are increasing the uric acid excretion, concentration of uric acid will be very high after giving this drug. So nephrolithiasis, urolithiasis risk will be a little high. But that's the reason why we don't use this uricosuric agents currently. But even though there are many drugs like probenecid, it's a very important uricosuric drug to note for exams, very sparingly used nowadays. I mean, we don't use anywhere. In my clinical practice, I've never used probenecid, to be honest. And we have another drug called a sulfinpyrazole. Each and everything has a unique mechanism and unique additional effect, but that's anyway not needed because we're not using sulfinpyrazole. And third is we have benzbromarone. It's like a congener of amiodarone, but it's not having any antiarrhythmic effect. That's called a benzbromarone. Apart from that, we have another drug. So for overproducers and in fact, in many of the underproducers, you're going to use this drug only very commonly. Even though it's expensive, you can use something called a pegloticase. So pegloticase is a recombinant form of uricase enzyme. So I can write in the bracket, it's a recombinant uricase enzyme. So where you can use pegloticase, not a problem. But remember, you have something called a rasburicase. That's also a recombinant form of uricase. Remember purine metabolism. Usually with the help of xanthine oxidase, you have uric acid formation. In humans, this is the dead end. So you stop at uric acid itself, but certain lower animals, with the help of an enzyme called uricase, they convert this to a compound called allantoin, so which is more soluble and easily excretable compared to that of uric acid. But humans don't have uricase enzyme. So that's why they stop at the level of uric acid itself. So why we stop at level of uric acid? Which means anything that happens with evolution should have some evolutionary advantage. So that's why the evolutionary biologists believe that this kind of uric acid that is found in the humans without getting converted to allantoin should have some kind of antioxidant properties to increase the lifespan. So probably that is the reason why we lost that uricase enzyme and now we are stopping at uric acid level. But some areas it can be deleterious, like when you produce too much uric acid, it can produce monosodium urate crystals, and that's causing gout and related problems. That's why lower animals usually does not develop gout, certain animals, because they have uricase. Only humans do develop gout. That is because of uric acid's antioxidant property, which is beneficial. At the same time, they are causing gout as well. So that is the reason why if you give a recombinant uricase, you can produce allantoin, which is easily excreted in the urine, and it's more water soluble compared to uric acid. So that's the basis of giving this pegloticase and rasburicase. As far as pegloticase is concerned, it's approved only for the treatment of chronic gouty arthritis or chronic hyperuricemia. As far as rasburicase is concerned, this is not approved for treatment of chronic hyperuricemia. It is used only for treatment of tumor lysis syndrome. We don't use rasburicase here. Only for tumor lysis syndrome, we should use rasburicase for that matters. One of the important points that you need to know with regards to rasburicase is you should avoid in patients with G6PD deficiency. That's the most important point. Do not use this rasburicase with G6PD deficiency. Instead, you avoid rasburicase in patients who are having G6PD deficiency. On the other hand, one more important point with regards to uricosuric agents is the fact that they should have a good renal function. Good renal function to have a good effect as far as uricosurics are concerned. Suppose if the serum creatinine is more than 2 to 2.5 milligrams per deciliter, if it's even more than 2, these drugs will not work, because as far as the uricosuric agents are concerned, they have to move into the kidney, into the tubular lumen to have some effect. If they cannot move into the tubular lumen because of the low GFR and high creatinine, so it is anyway unlikely to work. It's not going to work anyways, nevertheless. So of course you are going to avoid usage of this drugs, especially if the serum creatinine is higher or the kidney function is lower, either way around. So this is how you are going to manage a patient with a hyperuricemia, and how you set the targets. I think this has a lot of information. So right from the time of differentiation into gout and pseudo-gout, how to manage a hyperuricemia. All these are highly beneficial in your exams because they are very commonly asked questions. And let us see some images. Only 2 images are important right now. So this we know. So this is a classic Ferguson we saw already. So this is a sort of a normal sacroiliac joint where you can see a normal joint here, Ferguson's view, but you can see here, I don't think I can see any joint line here. So this is completely ankylosed and sclerosed. So this is a definite sacroiliitis. In fact, I will call it a late sacroiliitis, and patients having severe ankylosis here. So that's a symmetric, so it's ankylosing spondylitis, of course. And then there's an example of a Martel sign, if you see here. So you can see this kind of erosions with overhanging edges. This is the typical erosion we are talking about. And that's overhanging edge also. And you can see a soft tissue mass. This is the, like that monosodium urate crystal deposition as a tophi that is actually looking like as if it's eating from the sides. That's why you have that bone erosion. And you can see a well-preserved joint line here. So there is no joint space narrowing or joint line limitation. So that's very characteristic Martel sign that is seen in chronic gout. And this is how the crystals of gout looks like, monosodium urate crystals look like. So they are needle shaped. So in exam, if you see this kind of needle shaped crystals, compare the clinical background and don't confuse with your, you would have studied something called osazones in your biochemistry center. Don't confuse with that. So read the clinical history properly. The patient has first MTP involvement and the image shows this kind of picture. So definitely it's a gout. They're telling it's a needle shaped crystal that suggests you of gout. So this is an example of a chondrocalcinosis where you're seeing this kind of a linear calcification that is more typical of a pseudo-gout. Remember, the bone is fine, but in the cartilage, you should really not see any kind of calcification. But if you really want to see, you can see this kind of linear calcification that's happening over here. You can see this, the linear calcification that we are seeing. And so many areas the cartilage are calcified. So this is classically a pseudo-gout in this setting. And this is the typical rhomboid-shaped crystals that are seeing in the setting of a pseudo-gout. So classic rhomboid-shaped crystals, which will be weakly positive birefringence if you closely examine the polarized microscope. And this is a typical example of a pseudo-gout. And these kind of images are very, very common in exams. I think the pseudo-gout would have made a good understanding right now. So I don't think we need to discuss about pseudo-gout anymore. Crystal arthropathies, very important for exams. Nilash is asking, please upload ECGs. Yes, I will do it. I mean, I don't really find that much of time because once I finish, I have a lot of other work to do also. But nevertheless, your request is definitely correct and I will try to upload as soon as possible. Then we have 2 other disorders which you need to know. One is called as acute onset Still's disease, very important for exams. This is one of the disease that very commonly, is mistaken for a pyrexia of unknown origin or some infection, because I have seen most of the time AOSD presents like a PEO. This is an off-label statement, so I don't want to really tell for exams, but in practice, like majority of the AOSD patients come as a pyrexia of unknown origin, which means like a few, most of them will be treated with multiple antibiotics. They come to us and later on we diagnose this as a AOSD. This is adult onset Still's disease. Adult onset Still's disease. Remember, I'll talk about the juvenile idiopathic arthritis in some time, but there is another entity called a J that's called a juvenile idiopathic arthritis. I mean, I think we can finish off here itself. So then only you'll understand what is Still's disease. As far as juvenile idiopathic arthritis is concerned, it should happen within 16 years. Previously, it was called as juvenile rheumatoid arthritis. Currently, this terminology is completely removed. It's no longer a juvenile rheumatoid arthritis because it is unlikely to be rheumatoid arthritis because this patient doesn't have any markers of rheumatoid arthritis, nevertheless. So it will happen in less than 16 years. That's why it's called as juvenile idiopathic arthritis. It has many types are there. There are basically 3 different types. One is called asymmetric oligoarticular variety, which is the commonest form, basically. This is going to be the most common variety. And we have the symmetric polyarthritis form, which is the second most common variety, and we have a rarest form called as systemic JA, systemic juvenile idiopathic arthritis. This is what we refer to as something called as a Still's disease, very rare form. That's what we call as a Still's disease in children. And as far as Still's disease is concerned, this is considered to be one of the autoinflammatory disorders currently, even though the classification is put under JA, but it's considered as one of the autoinflammatory disorders where there is a problem in the innate immunity, not in the acquired immunity. If you have a problem in the acquired immunity, like B cell, T cell pathways, you call autoimmune disorders. If you have a problem in the innate immunity, neutrophils and all this stuff, you're going to talk about a autoinflammatory disorder. So that's the difference between autoinflammatory and autoimmune disorder. It's currently considered to be one of the examples of autoinflammatory disorders right now. Systemic J, systemic juvenile idiopathic arthritis. But usually the clinical feature will be arthritis. That's going to be the clinical feature. And it can be, different. Like it could be mono or polyarthritis. Mono is rare, but it can be oligo or polyarthritis. I think I should have written polyarthritis here, not oligoarthritis, semantic polyarthritis. So it can be oligoarthritis, or it can be polyarthritis, or it can involve 3 or 4 joints, doesn't matter. So there will be some form of arthritis, plus or minus. If the patient is having Still's disease, the patient will have fever, the patient will have hepatosplenomegaly, and the patient have elevated total counts and all this stuff, which means it's a generalized illness. That's why it's called a systemic JA. But most important feature will be the arthritis in these patients. Apart from that, around 20 to 25% of the individuals may develop a sort of anti-uveitis also. So that's why previously it is thought to be HLA-B27 associated. Currently they have removed from HLA-B27 related arthritis as well, but 20 to 25% can develop anti-uveitis. That's why you should not call it as JRA, because in rheumatoid arthritis, anti-uveitis is not a possibility. And at the same time, they can develop growth issues. So they develop growth problems because it's affecting the, like the epiphyseal bones and all. So you can result in growth problems. They can have a short growth if you don't treat this on time. And more importantly, as far as the investigation is concerned, there will be RF negative, there will be ACPA negative, and of course there will be ANA negative also, which means they will be completely seronegative. And treatment with, of course, you're going to treat with steroids. And DMARDs. These are disease-modifying drugs. You can treat with DMARDs as well. Disease-modifying anti-rheumatic drugs. Fever, hepatosplenomegaly, and we are talking about increased total counts. Total counts means WBC counts we are talking about. Increased TC, which is a sign of a systemic involvement. We're talking about here. Clear? This much I think is enough for knowing about juvenile idiopathic arthritis. I don't think there'll be so much questions from that. But nevertheless, you have to know about adult onset Still's disease, which means AOSD is also some sort of autoinflammatory disorder only. But it will not happen in the juvenile group, which means the age group must be more than 16, but it will be within 35. So usual age group where the adult onset Still's disease is involved is 16 to 35 years. So which means it is like a Still's disease only, but happens in the adult population. So that's why usual age group of diagnosis of AOSD is approximately 16 to 35 years. Usually what will be the clinical features? Clinical features in AOSD will be fever, most importantly. That's going to be the most important. And at the same time, they'll be having something called arthritis. And fever means, as per the diagnosis, we have a diagnostic criteria for that. That diagnostic criteria is what we refer to as something called a Yamaguchi criteria. That's called a Yamaguchi criteria. So according to Yamaguchi criteria, the fever will be there for at least, like 1 week. It should be at least for more than 39 degrees C for at least more than 1 week, number one. And second, we have arthritis. Evidence of arthritis will be there, of course. So either it could be either an arthralgia or at least an arthritis. So which will be there for at least for more than 2 weeks. So at least 2 or more joints should be involved. That's the idea here. And at the same time, they'll be having that characteristic rash called as a Still's rash. So that's described as an evanescent salmon colored rash. It will be like a reddish pink kind of a rash. So that's an evanescent salmon pink. If you get this word called as a salmon kind of a rash, that salmon colored rash, typically in the trunk. So that is very likely to be a Still's rash in exam. So that's one very important diagnostic criteria. And of course, majority of the patients will be having elevated WBC counts, and it will be usually 80%, more than or equal to 80% will be neutrophils. In that, more than 80% will be neutrophils in this. And like whenever a patient is having a fever, increased WBC count, rash, arthritis, of course, like I'm not going to diagnose this as a adult onset Still's disease. Many of the times I'll be talking about infection. Even disseminated gonococcal infection also can mimic similar picture, where they can fever, arthritis, elevated WBC, rash, everything can be there in disseminated gonococcal infection. But the identification of the Still's rash is more important. In gonococcal infection, it will be more often having a grayish kind of a base, but Still's rash will often have this kind of a salmon kind of a base. But nevertheless, I have to rule out other possibilities also. That's why many of the times these patients will be initially treated with empirical antibiotics. They won't resolve. They'll think of infection. They'll treat with more antibiotics. It will not resolve. And patient will come to us as a pyrexia of unorigin most of the times. That's how they present. Apart from that, they can have some minor features like influenza-like illness, like sore throat can be there in these guys, and they can have lymphadenopathy. They can have hepatosplenomegaly. That is because of systemic involvement. And they can have hepatitis, like they can have more transaminases like ALT, AST might be elevated. And again, all these things will make you think towards an infection only, because ALT, AST elevation can happen in typhoid, dengue, any kind of scenario. So it will not really tell you that it is Still's disease. That's why it's a diagnosis of exclusion most of the times. And at the same time, most important fact is, because the patient is having arthritis, you have to rule out seropositive arthritis, which can also present in similar scenario. So you have to tell that RF is negative, ANA is negative, and ACPA also will be negative. So you don't have any kind of antibody that will be positive. Very important point. And often not given in the diagnostic criteria. Remember, these are the major diagnostic criteria for AOSD, and these are the minor diagnostic criteria for AOSD. They're telling diagnosis can be established, suppose if there are at least overall any among the major and minor, if there is 5 diagnostic criteria, or at least if you have 2 major diagnostic criteria plus at least more than 3 minor diagnostic criteria, it's been said that you can make a diagnosis, but still you have to rule out the other possibilities before that. And more importantly, one point that is not given in the diagnostic criteria that is often found in patients with AOSD is the fact that they have extremely high ferritin. And I've seen a lot of cases of AOSD, like 10 to 12 cases of AOSD I've encountered till now, but everyone I've seen, like, ferritin is extraordinarily elevated, even though this is highly non-specific. With ferritin, I cannot diagnose, but that's one of the important clinical clues that we take. Like ferritin will be in 10,000, 20,000. Usually normal values of ferritin is 10 to 200 maybe. But in this patient, there might be 10, 20,000. Even I've seen 34,000 ferritin in one guy. So that's because of systemic inflammation that is going on most of the time. And as I said to you multiple times, it's the identification of the salmon rash that is often present in the trunk and the extremities that's going to be the most important clue. So Still's rash, as I told you, it will be more salmon in nature. That will be like that salmon pink base will be there in Still's rash. And apart from that, there can be macular or maculopapular. And at the same time, they will not be itchy. They will not itch. They will be non-pruritic. Not itchy, salmon-colored macular rash, typically seen in the trunk and probably in the extremities, is what we classically refer to as something called a Still's rash. And this rash can exhibit something called a Kubner effect, Kubner phenomenon, was studied in dermatology. So whenever there is a trauma in an area, that area can be precipitated by getting a new rash. So that's what we refer to as a Kubner phenomenon or Kubner effect. And like you can get Kubner phenomenon or Kubner effect in this patients with Still's rash as well. New rash can happen along the lines of trauma. Yes, that's Kubner phenomenon. So of course, these are the basic features of adult onset Still's disease, and the criteria that is used to diagnose Still's disease may be asked in exam. That's called a Yamaguchi criteria. The name alone is important. And treatment is like routine arthritis only. Usually, remember, whenever you talk about an autoinflammatory syndrome, usually autoinflammatory syndromes will be due to IL-1 mediated. Most of the autoinflammatory syndromes, including Still's disease, it's thought to be due to IL-1 mediated. So that is why anti-IL-1 will be very effective, and the pathways that block the IL-1 production also will be very helpful. Like TNF is one of the important stimulators for the macrophages to produce interleukin-1. So anti-TNF drugs will be very effective, and anti-IL-1 drugs will be very effective. So you can use these kind of immunomodulators. But nevertheless, you start with steroids to begin with, whether it responds or not. Then you can move ahead with a steroid sparing agent like methotrexate. Even if it doesn't respond, you can go with biologicals. Biologicals, what we use is anti-IL-1 like anakinra. Very, very helpful here, especially in autoinflammatory conditions like Still's disease or even in AOSD. Or you can start with anti-IL-6 receptor like tocilizumab are also helpful, and anti-TNF, of course, is going to be helpful in this scenario. Which means you're going to treat similar to that of rheumatoid arthritis only. Even though the patient is not having rheumatoid factor positivity, we'll be treating with drugs that are going to be effective for rheumatoid arthritis as well. But remember, rituximab will not be helpful here because I don't really see any serology that is positive. When the antibody titers are not there and antibodies are not positive, I don't really feel the need for rituximab will be here, because what you're going to do by giving rituximab here? So there's no need for rituximab, of course. So you can treat these things very easily. So this is an AOST, very important. So any patient in exam with fever, the typical Still's rash and arthritis, definitely it's going to be a adult onset Still's disease only. And next is we have relapsing polychondritis. Relapsing polychondritis. Only 2-3 words is important for relapsing polychondritis. The name tells polychondritis and it's relapsing. So which means you're going to have cartilage inflammation at multiple sites. That's all. Wherever there is a cartilage, there'll be inflammation. For example, joints can be involved. Prognosis of AOSD is good, reasonably good. It's not bad. If you treat well, it will be good. I've treated a variety of patients, so they are doing well, basically. If you don't treat only, it will be a problem. Even one patient with AOSD has gone for HLH kind of a scenario, that is hemophagocytic lymphocytic syndrome. So they've gone to that kind of HLH kind of scenario. But if you don't treat them on time, they can go towards HLH. But apart from that, the prognosis, if you treat early, is going to be much better in that scenario. But polychondritis, okay. As far as relapsing polychondritis is concerned, it's going to be the cartilage inflammation at multiple sites in the body. And most importantly, you should understand that almost half of the patient, that is 50% of the patients, one half of the patients will be having some underlying illness. Underlying systemic illness will be there. Underlying systemic illness will be there. Like, for example, the patient may have other continuity disorders like SLE or Sjogren syndrome. Some underlying CDD will be there, or mixed continuity disorder can be there. Or patients can have an underlying malignancy. So some underlying disorder will be there in almost half of the patients. So and it's a cartilage inflammation at multiple sites in the body. So for example, the cartilage, it can be in the joints. For example, it can affect the joint articular cartilage. It can affect the pinna. It can affect the alar cartilage. Alar means the nose. The nose cartilage can be there, and they can produce eye inflammation, ocular effects, ocular inflammation. They can even produce this laryngeal and tracheal inflammation, because laryngeal and tracheal area also have a lot of cartilages. They can produce cartilage inflammation in multiple different areas, but in exam usual location, to avoid confusion, they will give pinna and the alar region. So this is the usual sites they will mention in exams if they wanted you to diagnose a relapsing polychondritis, because other areas, if they give, you will be confused. They know that. That's why they typically give this pinna and nose involvement. If they're having recurrent inflammation of pinna, nose, you might be probably thinking about a relapsing polychondritis in that setting, especially in the setting of an underlying SLE sort of a scenario. Then it's confirmed it's a relapsing polychondritis only. But remember, it's a kind of a non-erosive arthritis. It's not an erosive arthritis. Even if they get joint involvement, it's more of a non-erosive kind of an arthritis. So that will be given specifically in exam to make you the diagnosis of relapsing polychondritis, because rheumatoid arthritis will be more of an erosive. In early stage, it can be non-erosive. But as far as exams are concerned, rheumatoid arthritis is a typical erosive form of arthritis. Any condition that produces high titers of rheumatoid factor or ACPA will have erosions. That antibodies are the reason for erosions. As simple as that. You have to think like that only. RF negative, ACPA negative. So usually in that setting, you will not get erosions in the first place. We'll discuss more about that in other CDDs like SLE as we move on. So usually it will be a non-erosive arthritis. Joint will be involved. Pinna, alar region in the nose, and ocular inflammation and laryngeal and tracheal region can be involved. And as far as the laboratory profile is concerned, you're going to get acute inflammation sort of a scenario like elevated WBC count, neutrophil predominance, CRP will be there. And you might have an anemia of chronic inflammation because there is underlying chronic problem is there, like CTD or malignancy. So that's okay. That's all right. So treatment of relapsing polychondritis, you're going to treat the underlying disorder if in case an underlying disorder is there. But more often, if there is no underlying disorder, you can treat it with NSAIDs. There's a first choice drug, which shows a good response most of the times, or you can use other anti-inflammatory drugs like Dapsone, but it's effective only for mild diseases. It's not effective for severe disease. So Dapsone can be used for mild diseases. And you can use methotrexate, azathioprine, and even cyclophosphamide. Suppose if the patient is having a life-threatening involvement, cartilage involvement, like lung cartilages are involved, that there's a respiratory failure kind of a scenario, in that setting you can even use a cyclophosphamide. But this is only for severe disease. For mild disease, NSAIDs and Dapsone will do most of the times. But final take-home point, as far as relapsing polychondritis is concerned, in the exam, multiple cartilage inflammation at different areas in the body. That is relapsing polychondritis. That's all. Most often you will have an underlying chondritis disorder, and at the same time, you might be having a non-erosive. That point typically will be mentioned in exam, non-erosive form of an arthritis, even if there is a arthritis. So I think this must help. Then we have to move to a kind of a septic arthritis. As far as septic arthritis is concerned, you have different kind of an etiology. Basically, in common practice, we split into gonococcal arthritis and non-gonococcal arthritis because gonococcal infection is very common in developing countries like India, where there is a high population of sexually active adults. Remember, India we call a young nation, isn't it? Because we have comparatively larger amount of younger population compared to that of other countries, other developed countries as well. So we are a young nation. So we have a lot of sexually active adults. So always there is a possibility of gonococcal dissemination. I've seen many cases. Actually, one boy who was just 19 years of age, he came with a rash, he came with a severe arthritis, very high grade fever. And this arthritis is a polyarthritis, multiple areas of the body is involved. And initially, like we are confused because he's like, like very good boy looking, like he's in a good family. There has been a good social support. Father is there, mother is there. So whenever father is not there, mother is there, we can think something else because they'll not be having that kind of a social support and control. So it's looking like a family support is good. Patient is having good family, but still is having this kind of feature. So we thought like something else. So anyways, nevertheless, I took a joint aspirate in the ward itself and we sent the culture. I mean, shockingly, like it came as a gonococcal dissemination. It's a frank gonococcus, and even in blood, like gonococcus was positive, even the blood culture. So we are very sure it's gonococcal dissemination. And he had a urethritis also, which actually we failed to, examine in the first sitting. Then later on, once the culture came positive, we saw the urethra had a discharge, and it was a gonococcal infection, of course. And we really don't know what's happening over here. So why this guy should develop a gonococcal arthritis. Then later on, retrogradely, when we involved a psychiatrist and when he asked the history, what's happening, it was actually an abuse, by one of his, probably like one of his father's relatives. I don't know to tell the name, but tell the relationship, but one of his father's relatives, she's a lady and she's been abusing him for a long time in kind of this kind of sexual reasons. So, I mean, it can present. So in India, it can be there in any form. And I've seen some form of Rita syndrome in young child, like 18, 19 is not called as child, but I generally call Indians 18, 19 is also child because they're still under the control of the parents. That's why. So I saw Rita syndrome that is due to the non-gonococcal urethritis in that guy. So still possible. Whenever a young patient is coming with kind of diffuse arthritis, multiple areas with rash, always suspect a septic arthritis. It could be either a gonococcal or it could be a non-gonococcal arthritis like Rita syndrome also. So always keep that in mind. That's the final take-home point. So don't get misled by the fact that they're having fever, rash, and arthritis means it should be something else only. So that has a variety of differential diagnosis. So let us see the etiologies of septic arthritis. So etiology-wise, septic arthritis can be bacterial etiology. We know that. In the bacteria, it can be non-gonococcal etiology. Non-gonococcal etiology. And at the same time, we have gonococcal etiology, I told you. It could be a disseminated gonococcal infection. I told you in the beginning itself, disseminated gonococcal infection can make a migratory polyarthritis as well. And we have viral arthritis. I mean, basically, like septic, or we can put infectious arthritis also. Because bacterial only will be calling it as septic. So any form of infectious. Viral arthritis are there. So we have variety of virus that can cause arthritis. Everyone when I ask, they will call about chikungunya, which can produce severe arthritis. Literally any virus can do this. You can get with hepatitis B virus, you can get with hepatitis C virus, you can get with acute HIV can produce arthritis and arthralgia. Then you can get with parvovirus B19. So many viruses are there which can produce infectious arthritis. And at the same time, you have mycobacterial arthritis. We can write as TB arthritis. TB arthritis is there. So TB arthritis can happen anywhere. It can be involving the peripheral joints, it can involve hip, it can involve knee, it can involve even the spine. That's called a pod spine, TB arthritis. You can have fungal arthritis. Typically, for example, you can have candida arthritis, you can have coccidioidomycosis causing arthritis, then we have histoplasmosis also causing arthritis. Candida typically affects the prosthetic joints basically. Histoplasmosis is very common in Western countries. In India, it's not very common. Histoplasmosis can cause arthritis, and we have something called a coccidioidomycosis. Coccidioidomycosis. So have you heard about the terms? What are the two terms that are associated with coccidioidomycosis? There are two terms are there. If you understand those terms, it will be easier. So what are those two terms with coccidioidomycosis? Both terms have been asked in exam, but old NEET exams, but currently I don't know whether they will ask or not. What are the two terms? Anyway, it's a US disease. I don't think in India you'd see that much of coccidioidomycosis. What are the two terms? Cracks. Okay. No, not really. So one, coccidioidomycosis is also referred to as something called as a valley fever, number one. Second one, coccidioidomycosis is given by another name called a desert rheumatism. Desert rheumatism. So these are two names. No. Coccidioidomycosis is not TB of the West. Histoplasmosis is TB of the West. So in like Western countries, you don't have TB. Like histoplasmosis is going to mimic exactly like a tuberculosis. They can produce the same manifestations like how TB has, like fever, weight loss, that kind of constitutional symptoms, and lymphadenopathy, cavities. Everything can be caused by histoplasmosis. That's why it's called as a TB of the West. And coccidioidomycosis more often is going to create that kind of a joint involvement, and that's why it's called as a desert rheumatism, or otherwise referred to as something called as a valley fever. A lot of other organisms that can produce this kind of infectious arthritis is Lyme's disease is there. Lyme's arthritis is extremely common in the setting of Lyme's disease. Then mycoplasma can produce arthritis. Then you have brucella can produce arthritis. Then you have Whipple's disease. One of the important extra-intestinal manifestation of Whipple's disease is arthritis. So Whipple's disease can produce arthritis, like the organism, it's Trophairima whipplei, which produce typically malabsorption, but there are a lot of extra intestinal manifestations of Whipple's disease as well. And Salmonella infections can produce arthritis. So there are a lot of variety of causes that can produce arthritis in the sense, but our concern right now will be the non-gonococcal arthritis and the gonococcal arthritis. These are two things that are extremely common in Indian practice, and that's why we need to know, because we have definitive treatment with antibiotics in non-gonococcal versus gonococcal arthritis. So first, let us finish off the non-gonococcal arthritis, then we'll move on to the gonococcal arthritis. Non-gonococcal. First, as the non-gonococcal arthritis is concerned, they can present in any ways. For example, they can come with acute monoarthritis, or they can come with a polyarthritis also. But most common presentation of any non-gonococcal arthritis is the acute monoarthritis. Acute monoarthritis. That is why, especially, they will present with a large joint monoarthritis. That's the most common. So that's the reason I told you, any acute monoarthritis in adults or even in children, if it's involving the large joint especially, then it is septic arthritis unless proved otherwise. You should not start with any kind of immunosuppression unless until you ruled out a septic arthritis in this setting. So that's the usual presentation. That's how they're going to present with. Apart from that, as I told you, the most common joint that will be involved in this particular setting will be the knee joint. We know that. So that's the most common joint. But apart from the knee joint, you can have the hip joint, you can have the shoulder joint, you can have the ankle joint, and doesn't matter, you can have any area involvement. So you can have hip joint, you can have shoulder joint, you can have ankle joint, you can have any joint can be involved, but the most common joint that will be typically involved is the knee joint in this particular setting. But is there involvement of axial joints? That you're asking. Axial joint in the sense, the sacroiliac joints, the vertebral joints, will that be involved? So whenever you have involvement of axial joints, you have to always suspect IV drug abuse. Axial joint involvement, you have to suspect IV drug user. So this is what you have to suspect whenever there is an axial joint involvement, very common in the setting of a IV drug user. Apart from that, in any other scenario, the most common joint involved will be the knee joint only. And apart from that, like what are the other features that these patients have? This is easily understandable. They will have an elevated WBC count. That's the total count will be elevated. I mean, this is not called as a reactive arthritis. Nilash is asking whether it will be a reactive arthritis. So whenever I tell septic arthritis, it is not a reactive arthritis. That's why yesterday I told you very clearly in the previous session, if you take carefully, I have told in this triad itself. Typically, I would have mentioned that this is a triad of Ritter syndrome, which I mentioned, where I have clearly mentioned that this is a sterile arthritis. You don't have any infectious organism here. But still, for safety, we are treating with antibiotics in Ritter syndrome, but this is not a type of infectious arthritis at all in the first place. This is not a reactive arthritis. Ritter syndrome is a form of a reaction to underlying infection. Or the infection is gone already, it's just an immunological reaction to that infection that is there. Apart from that, it's not an infectious arthritis. So you should not consider Ritter syndrome as an infectious arthritis in the first place. It's not a septic arthritis. We're now dealing with a septic arthritis right now. So they can have elevated total count, they can have fever with or without chills, they can have other generalized features of sepsis, they can have elevated CRP, ESR. So highly non-specific entities. But we know there is something wrong that is going on in these patients. That's what we need to know. Of course, whenever I'm going to see something like that, my investigation of choice, of course, because it's a large joint monoarthritis, my investigation of choice in this kind of a setting will be joint aspiration, which means I'm going to do a synovial fluid analysis in this scenario. So once I do a joint aspiration, typically I'll be seeing a characteristic feature of a septic fluid. You know how will the septic fluid will be? Typically it will be having counts more than 50,000, more than 90% will be neutrophils, and most often culture will be positive. So this is how a typical septic fluid is going to be. Remember, the counts are not important. Even if it is less than 50,000, that's okay. This neutrophils are more important rather than the counts. Counts can be less. Sometimes if you have preliminarily treated with antibiotics, the counts can drop down dramatically. So in that setting, the neutrophils will form a key, and most of the times the culture will be positive. Usually synovial fluid culture itself is more than enough. 80 to 90% that itself will be positive. But if the patient has already got some antibiotics, 1 or 2 doses of antibiotics already they've gotten, then in this setting, the synovial biopsy will have a higher sensitivity. Synovial biopsy will have positivity by approximately 90 to 98%. Synovial biopsy invariably will be positive. So synovial biopsies, especially during debridement, the synovial biopsy will be more useful, if at all. But in a simple joint aspiration, it's unlikely to get a synovial biopsy. Only during joint debridement, you can do a synovial biopsy. But in setting of a simple aspiration, your synovial fluid culture itself is enough. And most of the times, if the patient has not got any antibiotics prior, that itself will be showing a good sensitivity, reasonable sensitivity, in fact. And there are a variety of risk factors for getting septic arthritis. So as far as the risk factors are concerned with septic arthritis, you have any immunocompromised host. Any immunocompromised state. For example, a patient is having a severe uncontrolled diabetes mellitus, patient is having connective tissue disorders like systemic lupus erythematosus or rheumatoid arthritis, because SLE rheumatoid arthritis patients will be invariably immunosuppressed because they will be using a lot of immunosuppressive agents. So having a CTD with and using an immunosuppressive drug, patient is having uncontrolled diabetes mellitus, patient is suffering from a cancer, using a chemotherapy, very elderly patients like age more than 75, and if the patient is having HIV infection, or the patient is having some other forms of immunosuppression like transplant individuals. So these are the patients who usually get this kind of septic arthritis. Number one, this is the number one risk factor. And second, if the patient is having a damaged joints in the setting of chronic, long-standing, severe osteoarthritis, rheumatoid arthritis, or the patient is having a prosthetic joint, That is a very high risk factor because it's a foreign body. The patient is having a prosthetic joint. In that setting, you can get, infection. And at the same time, the patient is having a systemic bacteremia. What are the conditions where you get a systemic bacteremia? Suppose the patient is having an infective endocarditis, the patient is an IV drug user, or the patient is having some kind of central venous line, for example, HD patients, hemodialysis patients who's having a central line for a long time. So central venous catheter for a long time. So all these are considered to be important risk factors. You can categorize into 4 basically: immunocompromised individuals, damaged joints, prosthetic joints, systemic bacteremia. Most importantly, these 2 categories are very, very important. Infective endocarditis and IV drug users, where you can have high risk of developing septic arthritis. Here, remember, we are talking about a non-gonococcal arthritis. We are not talking about a gonococcal arthritis, for your kind information. And how you treat. So now you know how to diagnose and how to treat. Remember, whenever you know it's a septic arthritis, you have to start antibiotics immediately. And remember, the surgical drainage is also very important. If you know it's infectious arthritis, the septic arthritis, the first thing that you need to do is give a good surgical drainage, give a clearance, because it's the focus of infection. There is an abscess kind of scenario. So drain it, and then only you're going to have a good improvement even with antibiotics. If you don't drain it, and if you straight away start with antibiotics only, that's not going to be that beneficial. Infection may be contained, but it will not be completely cleared. So surgery is very important. Debridement, joint debridement, surgical drainage is very important. And during surgery itself, better to take a synovial fluid biopsy. So once you have taken a synovial biopsy and synovial fluid biopsy, then in this setting, you can start with antibiotics. So initial antibiotic regimen will be an empirical antibiotic regimen. Later on, once the biopsy reports arrive, then you can taper the antibiotics to more selective antibiotics for that particular organism. You can de-escalate or escalate antibiotics based on that culture report. But initially, you have to start with some form of empirical antibiotics. Depends on the organism. So if they ask you the most common organism in any kind of septic arthritis, or non-gonococcal arthritis, most common organism is always going to be Staph aureus. So of course, you are going to start treatment with Staph aureus cover. At the same time, you can have gram-negative bacteria also. So that is the reason why empirical treatment usually will include vancomycin, plus we'll use a ceftriaxone very commonly. Ceftriaxone is the one that will be very commonly used. Or alternative to ceftriaxone will be piperacillin tazobactam. Piperacillin tazobactam can be used in case if you suspect a pseudomonas. In case if you suspect a prosthetic joint, in case if you suspect a pseudomonas in that setting, then you can add a piperacillin tazobactam. But the most of the time, the empirical regimen will be vancomycin and a ceftriaxone. That itself will be more than enough most of the time. If you think pseudomonas, then you can add you can use, because there is no point in adding 2 beta-lactams like piperacillin tazobactam and ceftriaxone together. You add either a piperacillin tazobactam or a ceftriaxone. If pseudomonal cover is also needed, then you don't add zone, then you add piperacillin tazobactam in that scenario. So most common organism, how many ever times they ask you, it's Staphylococcus aureus. Even in a normal joint, even in a prosthetic joint, even in a damaged joint, no matter what, it's going to be a Staphylococcus aureus only. So depending on the organism, you can give treatment. For example, if it's a Staph aureus, or if it's going to be a Staph epidermidis, the usual treatment, Staph epidermidis is a type of squamous negative Staphylococcus. The usual treatment I'm going to start is with vancomycin only. All right. Then if it's a Streptococcus, clearly if the culture reports show Streptococcus, then in this setting, most of the time, your routine beta-lactams will be enough. Even a simple penicillin G will be enough for Streptococcus, but more often, we'll be treating with either ampicillin, sulbactam, or you can use it with the maybe ceftriaxone also must be enough in this scenario. But ampicillin, I think, will be more than enough for Streptococcus. Then number 3, we can go to some gram-negative bacteria. For example, if you are having a Pseudomonas suspicion, or if you are having a Serratia. Serratia also is a kind of infection that usually happens in the setting of immunosuppressed state. And if you are having a E. coli infection, in this setting, either I can start with the ceftriaxone or I can start with the piperacillin tazobactam. But in this setting, if you have a pseudomonal suspicion, it's always better to start with the piperacillin tazobactam in this particular setting. Clear? See, gonococcal arthritis, of course, I'm going to start with ceftriaxone only. There's no doubt about that. Ceftriaxone is one of the gold standard drugs for gonococcal infection. Maybe localized or disseminated, doesn't matter. But in this setting, because Pseudomonas serratia E. coli suspicion is there, means then in that setting, I'll be starting with the piperacillin tazobactam. Remember, Staphylococcus cover sheet is mandatory. Most of the patients will have Staphylococcus. So Pseudomonas serratia E. coli and all is typically seen in immunosuppressed individuals, IV drug abuses, immunosuppressed individuals, very, very elderly patients, those are having associated gastrointestinal tract infection, because these are usually typically gastrointestinal organisms. These are Enterobacteriaceae. So if the patient is having associated gastrointestinal tract infections, then you can think about these organisms and you can start with piperacillin tazobactam or ceftriaxone. This is tailored therapy, but nevertheless, the empirical therapy is something that they will be asking on exam, because tailored therapy they don't really ask. So you can start with vancomycin and ceftriaxone in this setting. Remember, minimum duration of antibiotics should be at least for 2 weeks IV. At least for 2 weeks, you have to give IV antibiotics minimum 2 weeks IV, and then followed by oral antibiotics at least for 4 to 6 weeks. An appropriate oral antibiotic at least for 4 to 6 weeks, which means the treatment for septic arthritis should be at least for 6 to 8 weeks in total. It's like infective endocarditis only. Even in infective endocarditis, the same treatment will be there. At least 2 weeks of IV and 4 to 6 weeks of oral antibiotics. This is for infective endocarditis also. But remember, IV, I told minimum is 2 weeks. Maximum you can give up to 4-6 weeks also. That doesn't matter. Depending on the response, the things will keep changing. But minimum you should give 2 weeks, both in infective endocarditis as well as septic arthritis, then followed by oral antibiotics for 4 to 6 weeks, which means the total duration of antibiotics will be 6 to 8 weeks. In a variety of scenarios. For example, in liver abscess also, you have similar kind of scenario only. There is a pyogenic liver abscess, same 6 to 8 weeks of antibiotics, 2 weeks IV minimum, then followed by oral antibiotics. But the antibiotic choices will change depending on the disease. But the duration of antibiotics for these 3 disorders I've told you is going to be the same. Then we can talk about disseminated gonococcal infection. So remember, disseminated gonococcal infection has some typical characteristic literature definition, literature clinical course is there. That's what we're going to talk about. Disseminated gonococcal infection, called as DGI. So usually it has a characteristic triad. So the first part of the triad tells you that the patient will have polyarthralgia, multiple joints will be involved. It can be symmetric or asymmetric, doesn't matter. There'll be polyarthralgia, and typically this polyarthralgia will be of migratory type. If you remember yesterday in the beginning itself, I would have told, I mean, whether you remember or not, in the beginning itself, I would have told this very clearly. So whenever in exam, if they give a migratory kind of a pattern, there is 2 things that you need to think about. I think migratory time of a pattern, there are 2 things that you need to think about. So one is going to be the acute rheumatic fever, and second is the disseminated gonococcal infection. So that's why yesterday I told you that point. That's really, really important. So they'll have more of a migratory kind of a pattern here. And it can involve small joints as well as large joints also. Small and large joints both are involved, but nevertheless, the most common joint involved will be the knee joint once again. That's going to be the most common. Clear? And at the same time, second characteristic feature is they're going to have this tenosynovitis, which means it can typically look like as if it's a rheumatoid arthritis along with tenosynovitis. So how will you diagnose it's a tenosynovitis? Whenever you stretch passively. So when, for example, if you want to test the flexor tendon, whether it's tenosynovitis there or not, when you stretch passively, there will be a pain. In acute tenosynovitis, whenever it's affecting extensor tendons, when you stretch passively, or which means when you flex. So stretching means you have to do an opposite direction to the action of the tendon. So when you stretch them, you will have a severe pain, and it's a form of an acute tenosynovitis, and patient will cannot stretch at any aspect. So tenosynovitis will be very severe in this scenario. So that's why that point is very important. And third thing is they will be having skin lesions typically. Skin lesions. Remember, typical area of having a skin lesion is in the trunk and in the extremities. Same like what I told you in AOSD, which means that location will not be specific, but the appearance will be very specific. They'll be looking like more of a grayish kind of an appearance, like how we see a pustule. And if it's more gray in color, pustule will be a little bit of yellowish blue, but it will be more of a grayish base. So the grayish base pustules is very characteristic. So that that we call it as a gunmetal powder. So gunmetal kind of an appearance. So that base will be there. So that's characteristic of disseminated gonococcal infection. So this is a typical triad of disseminated gonococcal infection. That is a polyarthralgia, that's migratory type, most commonly involving the knees, then followed by wrists, then followed by ankles. This will be the joints that will be very commonly involved, but trust me, it can involve the small joints as well. There will be tenosynovitis, and there will be typical skin lesions if you want to know. And many patients may have associated urethritis also. If it's untreated, they'll be having associated urethritis as well. And you have to take the urethral swab to confirm. And along with that, they might be having rarer complications like, that's called a perihepatitis. So whenever in a gonococcal infection, if you get a perihepatitis, what is that called as? I mean, this kind of questions a final year student should be very avidly answering. They know that because they would have studied that. So once I ask something they have studied, it should be a very fast reply. Yeah. Yeah, of course. Perihepatitis, but it's a very rare complication that's called a Fitzhugh-Curtis syndrome. But nevertheless, I don't think this will be asked in exams, by the way. That's a perihepatitis, and they can have associated pericarditis, they can have associated myocarditis, they can have associated meningitis, they can have associated osteomyelitis as well. Clear? So many things can be associated with them, but usually I look for this urethritis only as a direct evidence. This is the most important of all. I mean, so many associations, these are rare associations, but my clinching association in this particular setting will be the urethritis I'm going to deal with. So many times you might confuse this as a Reiter syndrome. That's why I told you, because Reiter syndrome can come with polyarthralgia, can have associated minimal tenosynovitis can be there, and Achilles tendinitis can be there in Reiter syndrome, and the patients can have skin lesions we have talked about, like sursnate Bellenitis and the pericardial glandular. But remember very clearly, this is an infectious arthritis. If you do a blood culture or if you do a joint culture, that will definitely show the organism. But in the setting of Reiter syndrome, it will not show any organism in the first place. That's a sterile arthritis. It's a reaction to underlying infection. This is actually an infectious arthritis, where the organism is actually causing the destruction and damage. So this is completely different from Reiter syndrome. Don't really try to confuse this with Reiter syndrome. And axial involvement is quite rare. You generally don't get axial involvement with that of disseminated gonococcal arthritis, but axial involvement is quite common with Reiter syndrome, that back pain, sacroiliitis, even though it will be asymmetric, but that's quite common. And HLA-B27 association is also quite high with Reiter syndrome compared to psoriatic arthritis, like 40 to 60% association HLA-B27 is there. So in that setting, the spine X-rays, the sacroiliac joint X-rays, and even your, MRI of the sacroiliac joint, and even HLA-B27 might be a little helpful. If you are really, really confused with Reiter syndrome, then that will be very helpful. But typically speaking, in reactive arthritis, you will not get a septic fluid at all in synovial fluid. It will be, WBC will be less than 90%, and total count will be around 3,000, 4,000. It will be elevated, but it will not be like 50, 60,000. Cultures will never be positive. Even if you do a synovial biopsy, should not be done. But even if you do, it won't be positive by any means. So definitely that's a sterile arthritis that you have to keep in mind for sure. This is a disseminated gonococcal arthritis, by the way. And as far as the investigations are concerned, so of course I'm going to do a synovial fluid analysis, that is joint aspiration. In that I'll be seeing a septic fluid. I'm not going to write the septic fluid again. I've written already 2 times, one in the tabular column and again in the last septic arthritis discussion. WBC will be more than 50,000, neutrophils will be more than 90%, and most of the time culture will be positive. And in this septic fluid, gram stain can be positive, but the amount of gram stain positivity is less, maybe around 10 to 30%. Only in this number of cases your gram stain will be positive, which means I'm seeing some organism in the gram stain, but that's not a reliable thing. And culture can be positive, but remember only 50% culture positivity here compared to the other forms of septic arthritis. But you know what is the medium that you have to follow, or what is the medium that you have to use in a gonococcal infection? What is the medium that you have to prefer? Otherwise, you will not get that culture positive. Again, it's a second year question, isn't it? It's a very easy one to answer. It's not a difficult one at all. Yeah, chocolate agar you can use, but the characteristic medium that you have to use is Thayer-Martin medium for gonococcal infection. If you use 50%, may show some form of positivity. And Other additional investigations are mandatory. It's not only the sinus fluid analysis. I definitely have to take the cervical and the urethral swab. And most of the times, one common thing that is missed is, of course, you will do gram stain, you will do culture, and all these things are fine in the swab that you're going to take. But more importantly, the most important thing is you have to do a PCR. PCR for chlamydia. This is a very notorious organism. Many times in STDs, along with gonococcus, you can have a chlamydia also. If you don't have gonococcus, then only chlamydial infection will become a non-gonococcal urethritis. But if you have gonococcus, there can be associated chlamydia. So that's why, being a very notorious organism, you always do a PCR. Yesterday I told you, that's a NAT, nucleic acid application test, because it cannot be grown in routine culture because it's an intracellular organism. That's a very notorious one. So you have to definitely do a PCR, even if you think about a gonococcal urethritis or a gonococcal infection for that matters. You can do other areas also. You can do swab, like for example, pharyngeal PCR. You can do a rectal PCR. You know why we are doing that. I don't want to explain that. Otherwise, you'll call me as a pervert. So you do a pharyngeal PCR. You're going to do a rectal PCR also for chlamydia. Fine. Nevertheless, you have to do some testing for chlamydia, of course. And as far as the treatment is concerned, treatment-wise, of course, the first line and the best treatment is going to be ceftriaxone only. There's no doubt about that. Because this is a disseminated gonococcal infection, you need to give 2 gram IV OD ceftriaxone for at least 10 to 14 days. Remember, localized urethritis alone can be treated with a single or 3 doses of ceftriaxone. That's going to be more than enough. But if it's a disseminated gonococcal infection, you have to give the antibiotics at least for 10 to 14 days. Plus, always give an empirical azithromycin. That is 1 gram stat dose should be given. Oral dose, 1 gram stat azithromycin should be given. That is to cover chlamydia. Even if there is no evidence of chlamydia, still, as this is being a very notorious organism, it's better to cover chlamydia with empirical azithromycin, 1 gram stat. So remember, usually what they will be asking you is, how will you treat a chlamydia? Chlamydia, the best way to treat is basically your doxycycline only. That's the best way. But there is one antibiotic that can cover everything. That is azithromycin. That's why you use azithromycin empirically in many gonococcal urethritis and non-gonococcal urethritis. For example, if it's a clear-cut gonococcal urethritis we are talking about, because there's another important question exam. So even though it's unrelated to rheumatology, that's because it's a question I'm telling you. Ceftriaxone is going to be the choice. There's no doubt about that. If it's a non-gonococcal urethritis, if you know the organism, it's fine. So for example, if you know chlamydia, suppose if you know it's a chlamydia, in non-gonococcal urethritis, chlamydia is going to be the usual one. If it's a chlamydia, then of course, yes. So your doxy is going to be the most important. So this is the best treatment for chlamydia when you know it's a chlamydia. If you don't know the organism and if you want to start with an empirical therapy, the best therapy is azithromycin. Remember, when you consider for chlamydia, if you consider doxy versus azithromycin, azithromycin is definitely inferior. It's not going to be that much helpful. But on the other hand, if you want to start empirically and you don't have evidence of chlamydia, then in that setting, azithromycin is going to the best choice, because in majority of times in non-gonococcal urethritis, azithromycin can cover almost all the organisms that causes non-gonococcal urethritis, including ureaplasma, ureolyticum. Many organisms are there. All this can be covered under azithromycin. But if you know it's surely a chlamydia, then doxycycline will be the best choice. If you know it's a gonococcal urethritis, then ceftriaxone will be the best choice. So they'll be asking you in exam, if in a non-gonococcal urethritis, if you want to start an empirical treatment, what is the best therapy to start with? Answer is azithromycin. If you know it's a chlamydia, for sure, doxycycline becomes the best. If you know it's a gonococcal urethritis, for sure, ceftriaxone becomes the best. So these are some of the antibiotic choices that you have to know for exams, very commonly asked. Rather than just mugging up the drug of choices, just remember this is the thing that we are going to use it in a practical basis. That's the most important one. I think the arthritis chapter is well complete, and there's nothing else that is left in arthritis. I think with this, I will close down the session because we need to start with a connective tissue disorder after this. So to start with CTD, we need a fresh mind. So you can go for lunch and you can come back maybe at 3:30 where we'll be starting with connective tissue disorders. And I think we'll be finishing CTDs and vasculitis today itself. So stay tuned. So we're going to finish all the rheumatology by today as much as possible. Bye-bye. See you. Yeah, 3:30. I mean, the connection is all well good. Surely I'll start by 3:30.